Hi there. It's amazing. There's a few of you still here. I started the day at 6:15, bookending the day. Um, this is why I love this meeting, because you have a presentation which tells you more opioid is okay and perhaps good, and I'm going to tell you why it's not. um, and so I'm going to talk a little bit about some of the evidence out there, not just from our hospital, but from MGH itself, which suggests that reducing intraoperative opioid dose is actually a good thing. I'm going to talk a little bit about the concept of opioid overdosing. Now, Toby's work, has stood the test of time, is reproducible. There's clearly, this sort of picture of an overdosed patient who's excessively sedated, for instance, but it's a lot more than just that. And I want to talk a little bit about waste, what the risks are with waste and what the outcomes are with waste. And finally, a little bit about how we might overcome some of the barriers. We've heard several things today around overcoming barriers, but some of the data from Brigham and other places, MGH again, showing how we might actually change human behaviors with medications. So overdose, like I said, we've got one presentation talking about inadequate analgesia, got another one talking about opioid-induced respiratory depression just before me, and clearly there's a bit of this harm thing that we're really concerned about here with APSF, but there's all this other stuff which we don't know. There's still data on both sides of the aisle here. So how much is too much of opioids? That's an important question. How much is too less, I guess, from Patrick's standpoint? Not going to go into this in great detail, but this close claims analysis clearly showed that severe opioid-induced respiratory depression is associated with harm outcomes. And although the percentage of claims is a smaller one, the outcomes, the tightness of the relationship is actually pretty strong. Ashish and others showed in a Prodigy secondary analysis that even the occurrence of one respiratory depression episode, as Toby showed, in a 130-second episode, is actually associated with increased length of stay and costs in hospitals. And so clearly you're defining a phenotype of a particular patient, as Toby said, who begins to fail in PACU and continues to fail after PACU as well. And so this is also overdose, right? So it's different. It's not the kind of overdose that we're thinking about, but this is overdose as well. And finally, from years back, these data from Mass General, which clearly show in a very large retrospective analysis that there is a dose response curve for readmission risks after surgery. Now, I don't know if this is the cause or the effect. It's clearly an association. But as you give more opioid, and the difference in dose here for the quintiles is not very large. We're talking of things that you and I quite regularly do in the operating rooms or see in the operating rooms. And particularly in ambulatory patients, there is a signal for a very strong dose responsiveness. So what we did was really begin to look at harm and this dosing as within the construct of error. This is the NCC MERP framework for medication errors. And we set about looking at what if we looked at these doses of intraoperative opioids as if they cause a problem, why shouldn't we be looking at it as an error? Now, we're not going to define it as an error. We think nobody's going in there saying, I'm going to use this dose and want to cause harm. But this concept we're trying to expand on here is what the incremental intraoperative dose is, and is it associated with these harm outcomes? The first harm outcome is an error that occurred that may contributed to or resulted in a temporary harm to the patient and required intervention. So these are things like post-extubation desaturation, postoperative nausea and vomiting requiring rescue treatment, postoperative somnolence or sedation requiring further observation of the administration of naloxone. And what we found when we plot out the probability of this outcome occurring, and on the y-axis against the dose given with equianalgesic dose, we find two important things. First, morphine has a very impressive dose response characteristic. right? So it's not a drug we use in our formulary right now for intraoperative, and perhaps it's good that we're not. The second is that hydromorphone clearly it sits a clear 5% above fentanyl for these patients. And we're really interested in, this was across all patients, we're really interested in ambulatory patients because that's really where the signal we're getting is. The second outcome of interest for us was that there was temporary harm to the patient and required initial or prolonged hospitalization. So this is category F, and we looked at delayed discharge related to clinical causes, predefined clinical causes. And this was an outpatient outcome. And other things we looked at were unplanned admissions from outpatient to hospital. We also looked at patients who were admitted to the hospital, delayed discharge from the hospital. And then finally, we looked at readmissions, and this was a composite outcome. And what's striking here is that even with very subtle doses, and here we're looking at patients who got the drug. Now, we're not looking at zero fentanyl or zero opioid patients. We're looking at patients who were exposed to morphine or exposed to hydromorphone or fentanyl. And the controls were more than 0 to less than 0.5, 0.5 to less than 1, less than or equal to 1, and 1. And you can see there's a clear dose response for each of these drugs. And so that suggests that there is at least a modest or even a strong relationship with the outcome of interest here. The pragmatist in me says, looking at this and looking at the data from other sites, that lower intraoperative opioid doses are associated with measurable, reproducible value. Now, you have to take this with a pinch or a sack of salt, based upon what Patrick has said. But with the data that we have from 2 large centers, 3 actually, if you look at the data out there, that it's associated with reduced early postoperative complication rates, reduced healthcare utilization, and some cost savings. Next, I want to jump into opioid waste, the hidden risks and costs. For this, we did a projected waste analysis. What we did here was we said, based on the dose that was given to a patient, instead of what was there in the OR on that day, what if we had, commercially available RTA preparations on that day, right? How would it stack up? And for this analysis, we had about 170,000 patients. For the costs, we also included the time that it would take to prepare a vial, and also the time it would take to waste a drug. Now, early in the day, I think it was Elliot or somebody who said, some people really don't care. We're going to pay anesthesiologists and CRNAs a flat salary. But we also heard from Amy that the overall sort of work that we do in a day, the complexity of the work that we do in a day, impacts things that we're not measuring right now. And what we find with the projected product size and waste is that we have about a 40% unit dosing with hydromorphone. So there's, for a 1 milligram hydromorphone, we've got about 60% of the times that it's used in the operating room, there's waste. Okay. Similarly, for fentanyl, that number is about 45 to 50%. And so together, you can see there's a large amount of waste that's happening in the operating room. If I project this across the whole of America, we could fill every year, I think, a 737 or a 747 with fentanyl and hydromorphone. Right. These are both drugs with a tremendous amount of potential for shortage, as we've all experienced in the past. And we look at the product size and cost. For us, it's about $75,000. It's not a large amount of money, but it's still important for us to factor. And if you consider the entire time and the effort involved, really it's equal to or slightly less than if you use RTAs in this projection analysis versus vials. When you look at predictors of intraoperative waste, you're thinking, maybe they're using less opioids because they're using adjuncts and other things. Really, the big thing that's sticking out is more than 1 opioid. The second somebody makes a decision to open 2 opioids for a case, you have almost an 8 times likelihood of having a waste event. We think, based upon data from MPOG, that this generalizability of single centers predictors is high, and there's only a 10% observed variance between various hospitals for drug utilization in the operating room. So in summary, unit dosing, you see them in about 50% of intraoperative opioid doses. Waste is 8 times more likely when more than one opioid is used, and there is some cost associated with it. So what are the barriers for change? One is the fact that unit dosing is very convenient, right? Earlier in the day, I was talking to various people, asking them, how do we end up with 1 milligram of hydromorphone or 100 micrograms of fentanyl as our standard in the operating room, or in some places it's 2 milligrams of hydromorphone? It's because we were taught by people to use that, and they were taught by people who are now dead, with no evidence to support any of our sort of behaviors over time. So in fact, the work that Patrick and I are presenting here are one of several, I hope, in the coming years, and I know Chad's group has done some of this as well, that will help us identify what we should be using in patients, right? So what if we could influence clinician prescribing and dosing behavior so that we improve the quality of care and reduce complications? For example, first, let's look at what happened when Mass General tried to standardize RTA syringe neostigmine. And I was part of this paper. Alok's here, maybe? Yes, Alok's on this as well. This is a great example of how you can introduce change in a holistic way. There's an entire intervention here, which includes, one of them is change from vials or previously uncontrolled neostigmine preparations to a 3 milligram neostigmine ready to administer syringe. And they also distributed these cognitive aids, had education, and built in a 1/4 of QI bonus into the salary. And the analysis was about a year's worth. What they found was the mean neostigmine dose decreased during the period, no surprise. There was a decrease in excessive neostigmine dosage, which has been shown to be deleterious for patient outcomes, and they had better TOF counts at the end of their cases. An outcome, this is where the money is, there was a 25% reduction in postoperative pulmonary complications during the study period. Their hospital length of stay was reduced by 10%, and their costs were reduced by 5%. All right? Here's a second example. Here's from Brigham here in Boston. There was a period of time when they were using 2 mil, just like most of us, fentanyl, and then there was a shortage. So for about 12 weeks, they moved to a 5 mil fentanyl vial, and then they went back to 2 mil fentanyl syringe. And guess what? When they went up to the 5 mil vial, just like Chad showed, he went back for a second helping, didn't he? And then when it went back, dosing changed. So I'm not saying that we're easily influenced by things around us, but it's pretty clear that the reason why we are using opioids with the doses that we're using them in is because of how they've been presented to us over time, and that can be changed, right? So much like many others, and I'm going to talk about what a high impact intervention is, I'm going to suggest here, and these are just my suggestions, with my conflicts of interest to go with it. I'm funded by Fresenius, so take this with a pinch or a sack of salt as well. But based on all the data that you've heard, not just from me today, I would suggest that choosing RTA opioid products over vials becomes really important when you're trying to standardize intraoperative opioid administration. The second is to consider patient outcomes and cost of waste. So really, we should be thinking about moving to 50 micrograms fentanyl for outpatient. And we're going to focus on outpatient surgery because it's actually 80 to 90% of our work right now. And if we're thinking of hydromorphone, really begin to think of less. Now, I'm going to say that you're going to hear differently from Patrick, but I think this work needs to carry on for us to begin to understand, how ultimately it needs to be prospective to identify whether or not we're going to have a positive impact on patient outcomes. Lower impact actions that really think about educating clinicians to choose the RTA size depending upon where you want to use it, and then educating clinicians to use one opioid. And finally, all this is great, but unless you've got a mechanism to measure and report back, there's something that Michigan did very well with Chad's stewardship around the work with opioids. unless you're able to show people that the things that you're doing have beneficial effects, you really don't get far with continuing this sort of work. So you want to make sure that you've got working with the healthcare quality groups in your hospitals to build the dashboards that you need to demonstrate improvements, or not, right? Even if it's true that reducing intraoperative opioid dosages is bad, we actually need to be able to say, show that and stop doing what we're doing. Right now, we just change things with no idea of their effects on patients. So key takeaways are really that intraoperative opioid dose restriction has clinical outcome implications. And so you can either choose that to be positive or negative. The evidence supports the use of standardized opioid RTA sizes as an effective way to influence administered dose and opioid waste or cost. And I really want to exhort you to consider the strength of your intervention when you're making change. Be bold. You're not going to make the change that you want with clinicians unless you build in forcing functions for the behaviors. Thank you.